Thank you for the introduction, and thank you for the previous lectures. That's been very helpful to us. I'm going to talk a little bit about podiatry and the specialisms and how we connect in the complex field of medicine. And I hope I'm not going to talk too quickly for the interpreters. So firstly, let's just look at a definition of medicine and the science and art of medicine. And it is dealing with, excuse me one moment, there we go. It's dealing with the maintenance of health and the prevention, alleviation or cure of disease. And then it says that it's a branch of medicine concerned with the non-surgical treatment of disease. So we are dealing with the foot, which is part of the human body, and we are therefore practicing a medical practice. In the UK, doctors take what's known as the Hippocratic Oath, which basically says that they swear to do no harm and only use treatments to the benefit of the patient and share information. We have a definition of podiatry, in an internationally recognized definition of podiatry, and that is that podiatry is that profession of health sciences concerned with the research, prevention, diagnosis and treatment of deformities, pathologies and injuries of the foot and associated structures in relation with the body, as well as the manifestations of systemic disease, by all appropriate systems and technologies using scientific and professional specialized knowledge. It's a bit clunky and a bit long, but it encapsulates virtually everything that we do as podiatrists, focused on the foot and the associated structures, of course, being what's above the foot. As a graduate podiatrist, as a podiatrist practicing, fully practicing, podiatry is an podiatrist is an independent practitioner who is expected to have independence of diagnosis and treatment. He or she takes full responsibility for their actions. We are therefore reflective, analytical, decisive, and responsible, which means that we are governed by what happens in the clinic, which is evidence-based. And of course, this all means, what does the patient expect? We are governed by the clinic, we are governed by evidence, and what does our patient expect from any medical profession, not just podiatrist? Overall, they would expect a good standard of knowledge, understanding of the human body, understanding of their problem, a professional approach, and that you are qualified to perform whatever treatments you are about to perform on them, which means that clinically, you should be skilled, you should be caring, and you should be gentle, and that you will do no harm, as we've just said, and to always have their best interests at heart. So this is what we are obliged to do for our patients. So looking at core podiatry, that is the standard podiatry, and this is taken from the webpage for prospective students at Brighton University's bachelor's degree in podiatry in the UK. And it says, quote, "You will study the core areas necessary for professional practice." That's the clinical sciences, health psychology, medicine, pharmacology, surgery, orthopedics, and research methods. It goes on to say, you will also share modules with students on physiotherapy, occupational therapy, and pharmacy courses, allowing you to exchange knowledge, expertise, with students from other disciplines. And this really is a good preparation for multidisciplinary team working, which is part and parcel of being a specialist in your field. Therefore, in my view, it is unquestionable that podiatrists practice podiatric medicine, and this is defined by their skills and abilities, but more importantly, the requirements of patients and their demands. So this core podiatric skills and knowledge can be focused on specialist need and specialist areas of treatment. Excuse me. Going on to define specialist podiatry and what a specialist podiatrist should be.
Ce înțelegem prin specialiștii podiatri și
This is taken from the Faculty of Podiatric Medicine of the Royal College of Physicians and Surgeons of Glasgow in the UK. The slide shows that there are key skills that is needed to really be a specialist in a field. There's clinical leadership, clinical knowledge, obviously, the ability to impart that knowledge and to involve other professionals. So that's teaching. And then there is research skills. To advance the specialism you have, you need to be able to take part in research and to assimilate research. So what are the specialisms? Well, to start with, most podiatrists will be in general practice. We'll see the conditions that come through the door and sit and into their clinics. So a general practitioner needs to have a comprehensive knowledge of all the specialists with the ability to refer on when necessary, but not necessarily focused skills and knowledge. And the ability to work with the specialists to maintain care. So once a patient has seen a specialist podiatrist, they may go back into general practice to be looked after and maintained. And on the right-hand side of your screen, there are a few of the specialisms that I want to point out to you today. It's not a comprehensive list. There are more, but these are the ones I would like to point out to you today, particularly diabetes, musculoskeletal, etc. So what is it about podiatry that warrants the designation of specialist? Well, as we've just heard from the previous lecturers, the foot in itself is a special case. And podiatrists, of course, understand this. It's not about knowing the anatomy, it's about knowing the function, how and why it goes wrong. And of course, the ability to put that right. It's also about knowing the early signs. If you think about diabetes, for instance, you need to know the features of a patient's medical and physical condition that will be intensified by foot problems. So if there is a foot problem there going into diabetes, that problem will be exaggerated by the diabetes. And you need to see the features of a patient's foot condition that will be intensified by the patient medical and physical condition. So it's looking at the two parts of this, and a podiatrist knows what to do about them all. It's the function and the ability to correct function and deal with pathology, specifically in the foot, that is the specialty, is the reason why podiatrists work with specialties. So looking a bit more closely at diabetes, assessment and management are the two sides of the problem here. So in assessment, we have assessment clinics where podiatrists will look at neuropathy, circulation and glycation and know the early signs that this is coming on. We know how to test for neuropathy, how to test sensation. We know the signs of circulation and circulation shutting down and circulation difficulties. And specifically, we understand glycation. And you'll have a presentation later about stiff feet, which is, I think, going to be explaining a little bit more about glycation. So podiatrists are there in the assessment and the forefront of assessing diabetic feet. We're also there in the forefront of managing diabetic feet. And this quote that I have here is taken from Professor Marion Kerr, who did an extensive piece of research on the value of podiatric care in the diabetic foot throughout the UK. And the link is there, and it's well worth looking at. It's from 2017, but interestingly, she said that reducing the prevalence of people with diabetic foot disease by 1/3 would save the NHS between £210 million and £262 million. So upwards of €300 million a year. And if the proportion of people with severe ulcers was also reduced, the saving would be even greater. And part of the work that she did, she looked at a part of Britain, a county called Somerset, where the GP set up a county-wide integrated diabetic foot pathway involving community podiatrists. And when they had done this, the major amputation rate in Somerset fell by 43%, averting an estimated 20 amputations a year. The estimated annual saving was over €1 million, almost 6 times the cost of the service. It shows that once podiatry is involved in diabetic foot disease, then there are benefits. Of course, mainly to the patient, but also financial. Excuse me. If we look at, excuse me, if we look at peripheral vascular disease or peripheral arterial disease, it's markedly affected by age. 3% of 60-year-olds rising to 20% in the older population. This problem reduces the foot's ability to combat force and pressure. If the circulation isn't there, the foot isn't nourished and it doesn't work in the way that it should. The tissues are less robust and infection can be considerably more dangerous. So early diagnosis through podiatry clinics, specialized foot care, reduces the incidence of major complications of PVD and PAD. We get there early so we can look after it early. By introducing lifestyle changes, people with PAD can expect an improved quality of life and life expectancy. And hospital admissions and amputations are reduced, and there are fewer premature deaths. So podiatry being involved in vascular disease is a good thing. It's very positive. Of course, as we've just heard, podiatry is all about looking after the foot and its structure. It's more mechanical issues than it is biomechanical issues than it is biochemical issues. And podiatrists are very expert in this sort of thing, and therefore should be involved in musculoskeletal clinics in any healthcare system. Feet are the base plate for all activity. The management of any lower limb pathology will need stable and properly functioning feet. This means modifying or correcting the forces acting on the feet to improve the mechanics of their function. I'll just say that again. This means modifying or correcting the forces acting on the feet to improve the biomechanics of their function. And we can do this in many ways, mainly with insoles, orthotics, or orthoses as it should be, and also with other techniques such as exercise, targeted exercise, manipulations, and strapping. Again, another little piece of research work that showed that if podiatrists supported the healthcare and primary care, it's estimated that 20 to 30% of all GP consultations are MSK conditions, and 10 million work days are lost annually due to MSK problems in the UK. And foot and ankle pain accounts for 8% of all GP MSK consultations. Providing a specialist MSK service in the community can prevent pressure on the general medical practitioners, GPs, and other secondary specialist services, such as orthopedics. So when a podiatrist is involved in a multidisciplinary team with doctors, nurses, orthotists, and physiotherapists, then the MSK problems are much improved. Podiatrists are experts in all aspects of foot and lower limb structure, function, and health. I would like to bring to you this little piece of research that was done by Menz and Lord, and this is one of their conclusions, that older people with a history of multiple falls have greater foot impairment than none or once only fallers. In other words, the problems of the foot in falls. It's a bigger risk factor, I think, than people generally think of. If your foot isn't functioning, then your base plate is lost, and it's entirely logical that that person will be more susceptible to a fall. This work was done in 2001. We are now 20 years later, and we still, in the UK, don't have podiatrists embedded in falls prevention teams around the country. It's getting better, but it still isn't there. The previous lectures showed a little bit about what happens when the foot isn't operating properly, and we know that arthritis is a major contributor to the stiffness of feet. And again, I'll say more of that later. But the foot is second behind the hand as the most common place for the manifestation of rheumatoid arthritis. And pain in the foot is commonly the most debilitating condition, which causes the patient to seek specialist help. In other words, the foot, it becomes painful with our rheumatoid arthritis in the early stages. And if we can do something about that, then we can help the patient greatly with their with their disease. So early intervention with appropriate foot care and biomechanical control will reduce the symptoms and progress of the disease, both osteoarthritis and rheumatoid arthritis. The arthritides can combined. So now we're looking at pododermatology. And I think it's pretty obvious that podiatry skills, core podiatry skills, would be very helpful in a dermatology clinic. Good targeted podiatry care can prevent many of the skin infections like tinea developing into more serious conditions, such as cellulitis. Giving simple but essential advice targeted to the condition. Screening patients for the presence of systemic conditions, e.g. diabetes and rheumatoid arthritis in a dermatology clinic, because often these things can show up there, and therefore preventing more serious conditions occurring. By early recognition and intervention, this can reduce the seriousness of skin conditions such as melanoma from developing. So checking for skin cancers, etc., is one of the things that the podiatrists do as of routine. Specialist podiatric dermatology clinics have been shown to reduce the burden on other healthcare professionals. Children, podopediatrics. I think this is a very rewarding area to be in and a very difficult area to be in. To know when to intervene with children is difficult and takes a lot of specialized knowledge, because it's all about how children develop. So podiatrists that specialize in children look after the consequences of childhood disease and congenital conditions. They use their skills and knowledge to help children develop as normally as possible. And that's that point in red that is most pertinent with children. I don't think you would have expected haemophilia to appear as a specialist area for podiatry. But this is something that illustrates the need for podiatry specialisms, in my view. And this is a piece of research work that was done through Leeds Health Board. And it was when there was a specialist physiotherapy and podiatry clinic in a haemophilia clinic, because severe haemophilia causes excessive bleeding into synovial joints and soft tissues, and this causes enormous damage. Repeated bleeds result in the development of erosive, painful, and disabling arthritis, and treatment involves replacing the low or absent clotting factor intravenously. And if you've ever worked with haemophilia, you'll know how expensive this is and time-consuming. So when a combined specialist physiotherapy and podiatry clinic was instigated in this health board, they used physiotherapy and podiatry skills to improve treatment, and which involved exercises, insoles, and modified footwear as required. This is to help the patients walk more efficiently and not to fall or turn their ankle or damage their joints, because that's where the bleed occurs. So getting them to walk more and move more efficiently was the plan of this clinic. And when this clinic was evaluated after a one-year pilot, it revealed a reduction in bleeds in children from a mean of 10.4 to a mean of 1.1, and in adults from a mean of 11.6 to a mean of 2.4. This is from a mean of 10.4 to 1.1 is pretty special, I think. And the cost saving in that year was counted in the hundreds of thousands of pounds, because the cost saving was that they didn't bleed, so they didn't need the clotting factor. So having looked at the specialist services, let me just explain a little bit about extended scope of practice. And the difference here is that these two features of podiatry require extra qualification, extra training and extra qualification, master's degree and above. In some countries, foot surgery is performed by podiatrists, not all foot surgery, but some foot surgery is performed by podiatrists, such as in the UK, the USA, Spain, Canada, Australia, etc. And the training involved in this is intense, and the education is postgraduate, and it's a qualification in foot surgery. What it's been shown is that when podiatrists are involved in surgery of the foot, it does reduce the burden on the hard-pressed surgical departments. Excuse me. Independent prescribing is where podiatrists have full access to all the general medicines list. And they also generally have admission rights. And in countries such as the UK, this involves extra training and education, again, for a postgraduate qualification. And that postgraduate qualification is noted in our registration. And this, again, reduces the burden on other hard-pressed medical departments. So in conclusion, There are many podiatric specialties, and I've noted just a few: musculoskeletal, podopediatrics, pododermatology, chronic disease, diabetes, rheumatoid arthritis, etc. Podogeriatrics, we talked about falls. Complementary medicine we haven't referred to, but many practitioners in the UK are able to use acupuncture and herbal remedies if need be. We have specialist footwear clinics, etc., etc. Embedded in the UK healthcare system, podiatry is making quite a difference to the patient experience. Just to note again, just to emphasize that to be a specialist podiatrist, you need to have clinical leadership. You need to be able to lead a clinical team and to be involved in a musculoskeletal, in a multidisciplinary team. That involves having extra clinical knowledge and understanding, of course, of the difficulties of whatever your specialism is, but also understanding of what the patient needs are. And you need to be able to impart this to the rest of the team and to other medical professionals. And of course, to fellow podiatrists. And this involves having research skills to undertake research projects, as well as to get the benefit from research. So, ladies and gentlemen, thank you for inviting me. Thank you to the organisers for inviting me, and to you, thank you for your attention.